So let's look at the importance of pain. Pain is the body's warning system. If you touch a hot stove, pain's going to prompt you to remove your hand quickly. Pain is an unpleasant feeling that lets us know something is not right with our bodies. Despite the unpleasantness of pain, it helps us acknowledge when we're sick. If you think about it for a minute, diseases that aren't generally associated with pain, such as hypertension, can be left ignored, and the patient may be unaware of the underlying disease process. With hypertension, they may have a headache, but in general, it doesn't cause a lot of pain, so it can be left ignored, untreated. So even though pain can be beneficial in letting us know there are problems, it's our responsibility as healthcare professionals to properly assess pain, implement needed interventions to control it, and also make sure we have an evaluation. Pain is a very important healthcare issue. It's the number one reason people seek medical advice. Again, no one likes to be in pain. When we're in pain, we know that something's wrong, so we seek medical advice. More than 50 million Americans suffer from chronic pain, and each year another 25 million experience acute pain as a result of injury or surgery. The Joint Commission is very committed to pain management. The Joint Commission, I know in Nursing 102 you heard everything DHEC. Don't do this. This is against DHEC regulations. Well, in hospitals, it's Joint Commissions who make sure and enforce policies and procedures within the hospital facilities. So the Joint Commission is very committed to pain management. It's so important they developed a 115-page monograph that's devoted to improving the quality of pain management. To meet Joint Commission requirements, all healthcare facilities must use pain scales, and the Joint Commission is really one of the big reasons that the assessment of pain is now the fifth vital sign. Failure to question patients about their pain on a regular basis and provide proper treatment and evaluation can result in citations from the Joint Commission. There are several pain theories out there, but I just want to share one with you, the gate control theory. This theory proposes that pain has emotional and cognitive components in addition to that physical sensation. So according to this theory, gate mechanisms along the central nervous system regulate or block pain impulses. So if the gate is open, pain is experienced. If there's no positive experiences, nothing good going on in that person's life, that gate is wide open and pain is going to be experienced and probably severe according to this theory. However, if the patient has positive experiences, such as a massage or stress relieving techniques, the gates can close and pain is prevented or decreased. Non-pharmacologic interventions can help close the gate and block pain. Now let's look at the origins of pain. Pain may be classified according to the area in the body which it originates. The three origins are somatic, visceral, neuropathic, and I also have cutaneous on here. All of these different origins of pain can also be classified as acute or chronic, which we'll talk about in a little bit. Furthermore, a patient could experience 1, 2, 3, or 4 of these types of pain. It doesn't have to be just one. So, first of all, somatic pain is pain that originates from the skin, ligaments, tendons, muscles, or bones. When it occurs in the musculoskeletal tissue, it's called deep somatic pain. An example of somatic pain would be a surgical incision. An example of deep somatic pain is metastatic bone cancer pain. Deep somatic pain may be described as aching, throbbing, gnawing. Surface somatic pain is usually sharper and may have a burning or pricking quality. Visceral pain is pain that originates from the internal organs, such as the heart, lungs. liver, kidneys, spleen, bladder, bowels, ovaries. An example would be pancreatic cancer pain, chest pain. Cutaneous pain, the origin, is in the skin or subcutaneous tissue. Neuropathic pain results from injury or damage to the nervous system. If you've ever experienced neuropathic pain or know anyone who does, you know that it can be very severe. It can be described as sharp, burning, tingling, stabbing. An example of neuropathic pain would be the shingles or diabetic neuropathy. Now let's look at pain transmission. Pain transmission has 4 phases: transduction, transmission, perception, and modulation. The first stage is transduction. This is simply your body experiencing the pain and your nervous system beginning to react. The nervous system changes painful stimuli in the nerve endings to impulses. The second phase is transmission. This is when the impulses are sent to the brain. The third phase is perception. During this phase, the brain interprets the impulses as pain, and the person experiences the painful sensations. The final stage is modulation. In this phase, the body attempts to decrease the perception of pain. This is when endorphins are released. Endorphins are natural pain-suppressing chemicals in the body. There are certain things, which we'll talk about a little bit more later, that we can do to increase endorphin secretion and production, which is going to help with pain, such as exercise, massage. Positive things can increase endorphin production and secretion. Let's look at acute pain now. Every type of pain can be classified as acute or chronic. Acute pain is usually caused by an injury or disease, and it disappears or goes away when the injury is healed or the disease is resolved. Acute pain can last days or weeks, and it may have the duration of 1 second to less than 6 months. So acute pain has a shorter duration, less than 6 months duration. It may last just a couple seconds or a couple minutes, but it's definitely going to last less than 6 months. Examples of acute pain would be post-op pain, a headache, a sore throat, a broken bone that, heals within 6 months and there's no more pain. That doesn't always happen with broken bones, but one that the pain lasts less than 6 months would be classified as acute. During acute pain, there are some physiological responses going on within the body. The patient's vital signs can elevate. They can have tachycardia, hypertension, anxiety, sweating, increased respirations. Now, when we get to chronic pain, we may not always have those alterations in vital signs because the patient has been dealing with this for greater than 6 months and the body's not accustomed to it, but it's accustomed to it enough where the vital signs may not increase, and we have to keep that in mind. Chronic pain lasts longer than 6 months, and it usually impacts all aspects of a person's life. Patients suffering from chronic pain may also experience fatigue, anxiety, depression, alterations in mobility, sleep, changes in their occupation, missed days at work, changes in relationships. All aspects of life can be impacted with chronic pain. Examples of chronic pain could be pain from cancer, rheumatoid arthritis, low back pain. And just as I said just a minute ago, you usually do not see the vital sign alterations with chronic pain. Let's look at some other types of pain. Referred pain is felt at a site different from that of an injured or diseased organ or body part. So, for example, with angina, however you want to say it, the pain experienced from angina, the pain experienced from coronary artery insufficiency, that pain can be felt in the left shoulder, the arm, the jaw. It's originating from the heart, but it can be felt in different areas of the body. It's referred pain. And in gallbladder disease, the pain may be felt in the right shoulder or scapular region, even though the gallbladder is the site of the original pain. Intractable pain is pain that's not relieved by ordinary medical, surgical, or nursing measures. Intractable pain is often chronic, persistent, and debilitating. It may also be psychogenic in nature. What this means is that it does not have a known organic cause, but it doesn't mean it doesn't exist. It just means we don't know the cause of the pain. And this type of pain is very difficult for patients, and it's very difficult to treat. Examples of intractable pain include low back pain, the pain experienced by burn victims. Phantom pain is pain that an individual feels in an amputated limb or other body part. So, for example, you have a patient who had a left BKA, a left below the knee amputation, and they still feel pain in that portion of the body, that left lower leg that was amputated. 50 to 75% of all individuals who have an amputation experience phantom pain. So it's very common after an amputation. We don't know the exact cause, but we know it's there. They may not only have pain in the amputated limb, but they could feel burning, tingling, itching, heat, cold, other sensations such as touch in the part of the body that's been amputated. Let's look at factors affecting the pain experience. There are many factors that can affect the pain experience. Pain threshold, pain tolerance, endorphins, age, environment, support systems, anxiety and stress, previous experiences. This list could go on and on. So let's talk about pain threshold. Pain threshold is the point at which a person feels pain. Factors that decrease that pain threshold, so factors that are going to result in a lower pain threshold, you're going to experience the pain earlier or more severe, not getting enough sleep, insomnia, fear, fatigue, depression, anger, stress, all decrease that pain threshold. Factors that can increase the pain threshold are going to be positive experiences, diversion, pain relief, sympathy, sleep, a good diet. Pain tolerance is the point at which a person can no longer endure pain or the amount of pain a person is willing to bear. We must remember pain is subjective and unique to each individual, so pain threshold and tolerance can vary from person to person. Endorphins are naturally, we talked about this a minute ago, naturally occurring substances produced by the central nervous system that help relieve pain. Endorphins are released with exercise, other forms of physical stimulation. A number of factors, however, can decrease endorphin production, which we don't want. Caffeine, nicotine, alcohol, salt, and sugar can all decrease endorphin production. We want those naturally occurring substances to be available in the body, so we want to avoid things that decrease them. Age influences how people admit or describe pain and how they behave. The expression of pain is also related to ethnic and cultural factors. For example, some cultures believe that pain is punishment from God. Some people believe that pain is weakness leaving the body, so they don't want to receive treatment for it. Some cultures do not believe in Western medicine and will only seek alternative methods to treat pain. A person's environment plays a role in their pain experience. Do they have access to shelter, food, water? Is their environment relaxed or chaotic? That's all going to impact and affect their pain experience. Support systems are very important for those suffering from pain, especially chronic pain. Is the patient surrounded by loving, caring people, or are they surrounded by people who really don't believe they're experiencing pain or tell them they just need to deal with it and stop complaining? Previous experiences, whether good or bad, is also going to impact the current pain experience. I want you to take a look at this diagram. This diagram compares an unbalanced day to a balanced day. Most of us are probably, if you described our lives, would be under the unbalanced day because work or school consumes most of our day and we don't leave enough time for rest, exercise, relaxation, meals, and so on. I hope we're all leaving enough time for personal hygiene. We may neglect some of the other things, but let's keep our personal hygiene up. So when we do this, we're predisposing ourselves to stress, fatigue, insomnia, and all these things lower that pain threshold. When you're taking care of patients who suffer from chronic pain, ask them about their daily schedules. Do they leave enough time for rest, relaxation, exercise? Are they eating nutritional meals? All things that can benefit their pain experience. Here are barriers to pain management. Poor assessment of pain. I mean, that's sad that that's a barrier, but we should be properly. That's just unnecessary. We need to properly assess pain. Fear of addiction. Underreporting of pain by patients. Age, cognitive and language disabilities, and disbelief by healthcare professionals, colleagues, friends, or family. The most common reason for unrelieved pain in the U.S. hospitals is failure of the staff to routinely assess pain and provide pain relief. That's sad. If pain's not properly assessed, of course it can't be managed. We play the most important role in the assessment process. Some patients needlessly suffer from pain due to their fear of addiction. We have to educate patients that there's a difference between tolerance, dependence, and addiction, especially our older population sometimes. They've seen the news stories about patients who are addicted to OxyContin and how it's destroyed their lives. So when they're in pain, they'd rather just suffer than take the risk of becoming addicted. But we have to provide education. Patients who suffer from chronic pain will more than likely experience tolerance and dependence, but not addiction. This means they're going to depend on their medication to function properly and control their pain, and they're eventually going to require higher doses of their medication because of tolerance. However, this does not mean that they are addicted to their pain medication. Patients who suffer from pain take their medications to reduce their pain and feel better, not seeking a high or to abuse the medication. It could help to explain tolerance and dependence to your patient by relating pain management and to other chronic diseases. So, for example, patients with hypertension are dependent on their medications to control their blood pressure, just as chronic pain sufferers are dependent on their pain medication to control their pain. Also, patients with hypertension may need the doses of the blood pressure medications increased or add new medications to control their blood pressure, to control the disease, just as chronic pain sufferers may need their pain medications increased or additional medication to control their pain. So you need to know the definitions for tolerance and dependence. Tolerance is when a higher dose of medication is required to obtain the same initial effects. And again, with chronic pain sufferers, that's going to happen. The body becomes accustomed to that dose and they need a higher dose. Dependence is when the body adapts to the presence of a medication and withdrawal occurs if the medication stopped. When a person is dependent on a medication, their body does not function properly without it. And so when we have patients on pain medications and they wish to stop them, they have to be tapered off or they're going to have some pretty bad withdrawal symptoms. Their body is accustomed to that medication. Patients who are addicted to medications have compulsive, often uncontrollable drug use in spite of the negative consequences. Another barrier is underreporting of pain by patients. Some patients don't report their pain to healthcare professionals because they don't want to bother them. They see how busy we are and they're just nice and they don't want to bother us. We have to let our patients know that we're never too busy to meet any of their needs. Frequently asking if they need anything and questioning, assessing for the presence of pain will aid in this process. Some elderly patients don't report their pain because they feel it's a normal part of aging. Pain is never normal. We have to educate our patients about that. Age can also be a barrier to pain management, and that we have to approach the issue of pain different with children than adults. Pain can be more difficult to assess in children, and different pain scales need to be used. So think back to the definition of pain that I told you that I want you to use. The definition that I told you I think is most important for healthcare professionals about pain is whatever the experiencing person says it is, existing whenever he says it does. What about patients who are not able to verbalize their pain because of cognitive disabilities or any reason? For some reason, they can't verbalize their pain. These people experience pain, however, they're unable to verbalize it. Millions of Americans suffer from dementia, and at some point in their illness, each one of them will be unable to verbalize their needs and their pain. We must anticipate their needs. When someone cannot verbalize pain or their needs to us, we have to anticipate their needs and look for nonverbal indicators of pain, such as moaning, grimacing, tachycardia, increased blood pressure, agitation, guarded positioning. You go to assess their stomach and they grab it. Well, maybe it hurts. Combativeness, restlessness, and changes in eating and sleeping patterns. The last barrier that we're going to discuss is disbelief by healthcare professionals, colleagues, friends, or family. Since chronic pain frequently cannot be seen, unlike a broken arm, many with pain are not believed. Remember, pain is subjective, and we have to listen to our patients. Please indicate which sensations you feel by referring to the key below. I'm also going to show you a pain diary, and on the pain diary, the patient just describes their pain as they're experiencing it. They write information about the pain, and then they take it to their physician so they can get more information about the pain. So actually, I'm going to post the pain drawing and the pain diary on Blackboard for you. They're not included in the slides, but here are a few others. Here's just the numeric, the one that we're most familiar with and we use most of the time, the 0 to 10 scale. No pain is a 0, worst possible pain ever is a 10. Here's the visual analog scale, and a patient just makes a mark. Where does their pain fall between these two levels? Wong-Baker faces of pain is used a lot in children or patients with mild dementia, and they just point at the picture that describes their pain. The checklist of nonverbal indicators is used a lot in patients who are nonverbal, and the whoever's completing this assessment just goes through and marks whether or not the patient is exhibiting the behaviors on this checklist. And if any of them are displayed, then they do a further assessment to see if it could be due to pain. So now let's take a look at medication history related to pain management. During your initial assessment, a medication history should also be obtained. So, questions you want to ask: do you have any allergies? What pain treatments are you currently using to control your pain? What have you used in the past? And you want to know both pharmacological, non pharmacological, as well as prescription and non prescription medications. What's worked well? What was not helpful? What side effects have you experienced? When was your last dose of medication? What did you take? How much did you take? This is really important especially if you're just admitting that patient. If they're complaining of severe pain, but they just took some pain medication right before they came into the hospital, you don't want to give them a whole lot more medication at that time until the initial medications had time to work. You should obtain the duration and frequency for each medication they're taking, the dose. Do they use any complementary or alternative therapies? Really important if they're taking any herbal medications, because herbs can interact with prescription medications. You also want to ask them, and this is part of the admission assessment at every facility, about drug and alcohol abuse. These substances potentiate the effects of many pain medications. Simply means the patient's pain medication will produce much stronger results. And we'll talk about side effects of those medications in a little bit. Let's look at results of untreated pain. We want to prevent these. There are a number of negative consequences of untreated pain, including delayed healing, impaired immune system, decreased mobility, decreased appetite, decreased sleep, depression, nausea, vomiting, needless suffering, and overall decreased quality of life. And then also increased healthcare costs. So let's say, for example, you have a patient, a post-op patient. They just had surgery. They're refusing to walk, use their incentive spirometer. They're not turning, coughing, deep breathing. And it's all because they're experiencing severe pain. They don't want it to hurt any worse. They're not going to do these things. If the nurse doesn't properly assess the reason the patient's not doing these things and properly assess and treat and manage their pain, they're going to be at risk for a number of complications, post-op complications, pneumonia, blood clots, constipation, just because we didn't manage their pain so they can do these things comfortably. Let's look at pharmacologic treatment for pain. We're just going to briefly look at some of the big classifications. So, first of all is acetaminophen. What you need to know about acetaminophen is it has a maximum effective dose. Increasing the maximum dose will not increase the analgesic effect, but can increase the risk of hepatotoxicity, which is toxicity of the liver. Tylenol is known for that. So right now, the maximum daily dose of acetaminophen is 4,000 milligrams. There's a lot of talk with the FDA about decreasing that to 3,500, possibly even 3,000. I think eventually it'll probably come down. You need to keep in mind, if you have a patient who's on a medication that is combined with acetaminophen, that has to be included. Those milligrams of the acetaminophen in that, like Percocet, has to be included in that maximum daily dose calculation. People with renal or hepatic impairments or failure should use acetaminophen with extreme caution. If they should use it at all, they need to talk to their doctor. So acetaminophen is used to treat mild to moderate pain, and hepatotoxicity is a side effect if people take too much they have to be careful about. NSAIDs, non-steroidal anti-inflammatory drugs, are also used to treat mild to moderate pain. They also have a maximum effective dose. Common side effects of NSAIDs: GI upset and bleeding. It's important for patients to take food with the NSAID to prevent the GI side effects. Examples of NSAIDs: aspirin, ibuprofen, naproxen. People can be allergic to NSAIDs. People with asthma can have some very negative side effects of NSAIDs, so they have to be careful. It's really important when we're educating our patients about pain management that we tell them to ask for pain medication at the onset of pain. If once the pain is very severe, it's too hard to control and get it back down. Sometimes as a nurse, I'd ask the patient, they said they're in pain. I assessed it. I said, do you want me to get you something for it? They said, oh no, I'll wait till it's a little worse. But we have to educate them. Once it's really bad, it's going to be too hard to properly control. Let's look at opioids, also called narcotics. These are used to treat moderate to severe pain. Examples: morphine, Percocet, Loratab. Side effects of these medications that you need to be aware of. These medications are very common, and we need to know the side effects as a nurse. Constipation is huge, and it's one of the side effects that doesn't go away. Many of these other side effects go away with time, but the constipation, patients who are on opioids usually need to be on a stool softener or something. They need to drink plenty of water and have fiber in their diet because constipation is a major issue. Respiratory depression, nausea, vomiting, decreased blood pressure, drowsiness, sedation, confusion. Respiratory depression is going to follow sedation. So they would become sedated and then have the respiratory depression. So that should alert us as a nurse. We have a patient who's on an opioid and they become sedated. Let's not let it get to the respiratory depression state. Most of these side effects, except for the constipation, go away within about 4 to 10 days. We need a preventative approach for the constipation. Exercise, fiber, stool softeners, fluid intake. They may need enemas or laxatives at times, but as you already know, they don't want to be doing those long term. For opioid overdose, Narcan is the antidote. It can reverse the effects of opioids. So when a patient's receiving an opioid, you need to frequently assess their level of consciousness, their vital signs, and ask them, when was your last bowel movement? Because we don't want them to get constipated. Patients who've been on long-term opioid therapy must be educated that they can abruptly stop taking the opioids because they could have withdrawal. Signs and symptoms of opioid withdrawal: diarrhea, abdominal pain, sweating, dilated pupils, elevated vital signs, anger, hostility. It's not pleasant. It's not comfortable for the patient. And that's why if they want to stop their medication, that they need to be slowly tapered off. They need to talk to their physician to get help with that. You need to know the difference between short-acting and long-acting narcotics. Short-acting should be used for breakthrough pain. These should be your PRN medications. And then patients who suffer from chronic pain should be on a long-term, a long-acting narcotic that they are prescribed around the clock. They take it every so many hours. We also have adjuvant medications. These adjuvant medications are medications that they were created or developed for other uses, but we've found that they can actually, usually in addition to pain medications, help control chronic pain. So there's anticonvulsants, corticosteroids, anti-anxiety medications, antidepressants. They can also enhance the effects of the analgesics that the patient's taking. They can decrease anxiety and stress, which lowers the pain threshold. So specific examples: Neurontin, Elavil, Tegretol, Depakote. Tegretol and Neurontin are helpful in neuropathic pain, such as shingles, diabetic neuropathy. PCA, patient-controlled analgesia. With this, patients are able to self-administer prescribed levels of medication. They have a constant plasma levels are maintained by small frequent doses that they automatically receive, but then they have a button they can push if they need a PRN or on-demand dose. The system is programmed using physician orders to deliver a certain number of doses, a certain amount, every 1 to 4 hours. IV or subcutaneous are the most common routes, but they get that constant plasma level, and then they can get that on-demand PRN dose if they have some breakthrough pain. Used a lot after surgeries. Other routes for pain medications, topical, transdermal, transmucosal. Creams can be great for children before procedures that can decrease or alleviate pain before they have to give them an injection or something painful. Transdermal, the example would be fentanyl patches. A fentanyl patch is 100 times more potent than morphine. So they wear this patch. This would be for severe pain. They wear it for 48 to 72 hours. Medication is slowly released over that time. Thing to know about these patches, as you take them off, there will be a facility policy on how you discard them. Some places we put it in the sharps container, but it has to be put in an appropriate place where someone's not going to get that patch and abuse it. Transmucosal fentanyl can be used for breakthrough pain. They swab it in their mouth and it dissolves. We also have something called a TENS unit, transcutaneous electrical nerve stimulation, and this is a neat little device. I've known people who've used them for things like low back pain, and they said that it helps. But this unit, they wear those electrodes over the area where they're having pain, and the idea is that it sends out signals that can interfere with pain transmission, so it could block the pain, and it may even help release endorphins that help with pain relief as well. Some non-pharmacologic interventions. These things are usually used in addition to pharmacological therapy. Chiropractic care, acupuncture, hypnosis, therapeutic touch, massage therapy, herbal remedies. I really recommend that you learn about these non-pharmacological interventions because they can be great for patients, and lots of our patients are using them. Billions of dollars are spent each year on these services, so we need to know about things that our patients are using or things that maybe we can recommend. Other things, exercise, physical stimulation, application of heat and cold, guided imagery, support groups, stress management, biofeedback, distraction, prayer, relaxation, music. Possible nursing problems or diagnoses for patients experiencing pain, especially chronic pain, but any type of acute or chronic. Anxiety, ineffective individual coping, hopelessness, risk for injury, impaired physical mobility, sleep pattern disturbance. And this list could go on and on and on.